Hello, everyone, and welcome to this webinar from YCE. And today we'll be talking about inclusivity, barriers, and best practices in LGBTQI plus cancer care. So, a topic that's super close to my heart as a patient and a professional in the space. And we've got lots of content to get through today. So, I'm really excited to talk you through it. So to start us off, let's see who else we have in the room with us, and we'll start with the audience. So we've created a graphic that's going to show you a little snapshot of who has registered for this event. It's a super diverse group, which is amazing to see. So we've got at least 23 people with lived experience, at least 44 healthcare professionals, 6 caregivers, 18 patient advocacy groups, 19 researchers, and 3 policymakers. So a huge spread, and it's amazing to see that you're all here. And where are you dialing in from? So we've also created a map, and you can see that from over 33 countries, we've got you all dialing in, and obviously a large representation from Europe, which is fantastic because we're going to have lots of recommendations for best practice today, lots of useful insights, and hopefully stuff you can take away and put straight into your local areas. So we're going to do a lot of content today. So we've got stuff where I'm going to give an overview of the topic and tell you a little bit about charity, my background and my interests. We've also got some conversations around what makes good policy, professional education, and we've also got a panel discussion. So I'm just going to introduce the panel speakers now. So we'll hear from us a lot later on, but it's useful for you to know who else is in the panel at this stage. So myself, Stuart, for those of you who haven't met me or heard from me before, I'm the founder and CEO of a charity called Outpatients in the UK. We're an LGBTIQ plus specific cancer charity, been around for around 5 years. And through this, I do a lot of health and policy advocacy. I'm also an academic researching in the space. I'm a visiting lecturer at multiple universities, and I create and contribute to different curricula. I also have expertise in oncosexology, so psychosexual impacts from cancer treatment, and I co-chair the ECO, so European Cancer Organization's LGBTQ plus work stream, and I contribute to YCE in a similar capacity. So joining me today, I've got Levi. So Levi is a queer artist and cancer survivor and has lived experience of cancer as a non-binary patient, currently studying art, English, and philosophy. Hi, Levi. Love to see you.
Hello.
Uh, We've also got Aleka. So Aleka and I work together at European Cancer Organization, but Aleka's definitely there full time. I'm just sort of a face that pops up every now and again, but it's lovely to have you with us.
Thank you. Lovely to see you.
Um, as always. And we also have Emily, who's a specialist in diversity data and inclusive training and helps organizations to implement sustainable inclusion strategies across various industries. Hi, Emily.
Hello.
So these are the wonderful people with me, and you'll hear from us throughout and then at the panel. There'll also be an opportunity to present some questions, so feel free to pop those in the chat box to the hosts, and we'll make sure that we take a look at them. So to start, I'm going to whip through a few slides to tell you a little bit about my charity, but then also give a bit of an overview of where we're currently at with the actual LGBTIQ plus topic in the cancer space. So as I said, my charity is called Outpatients. Here you've got a lovely photo of us here. So you've got staff and service users all bundled together, which is the way we like things to be. Next slide. And what do we do? So we support patients. So this is a photo from one of our specific groups. So this is a breast cancer support group that we run. Next slide. We also raise visibility of the topic. So we speak at conferences, international stages, we give patients the opportunity to speak, and we also try and influence the government in positive ways. Next slide. And we also create campaigns that speak directly to the community and are co-developed with the community. So here you have us at Happy Valley Pride with our cervical screening campaign. Next slide. We also publish a lot of information. So this can either be professional guidance we've written or co-written. It's also posters. It's advertising our peer support, which is available online. We also support and co-author national clinical guidance. And then we also support active research in the field with experts too. Next slide. We educate professionals as a charity. In the last year, we reached over 3,000 and they always rate it very highly, which is fantastic. We specialize in lunch and learn for clinical webinars. And we can also show there's a significant improvement in their awareness, knowledge, and confidence over our education. And every year we run a conference on this topic. So if you are someone that is locally doing great work on this area, keep this in mind. We do have international speakers. We had ECO dial-in last year. We had people from Canada as well. So we very much want to center and platform excellent work that's happening in this space. Next slide. So now the sort of overview bit. What I intend to do here is move quite quickly, but just to give us all a real understanding of what has been achieved, where else we've yet to go, and then hopefully this will line us up for the rest of the content in the panel. So I'm going to plot this across the cancer pathway as a reminder for people. We'll start with sort of awareness and public health. We'll move into the first point of suspicion, so screening, GP appointment or emergency appointments. Then we've also got diagnosis, treatment decisions, treatment, and then the living with and beyond space. Next slide. So in the awareness space, I think when I reflect on what I've seen, at least in the last 5 years, we've seen an improvement for representation in some of these health campaigns. We've also seen a little bit of direct work in targeted smoking cessation, which is fantastic. And we've seen greater discussion, especially internationally, around policy for EDI, as we obviously know from this topic, but where to go next. So we need to make sure that this representation is also matched with good information so that people can make informed decisions. This will allow us to address some healthcare myths because people are still getting turned away from vital things like screening just because of who they are. And we also need these discussions around policy to be actionable and measurable so we can get some progress. Next slide. In the screening and sort of point of suspicion stage, we have seen, at least in the UK, some improved guidelines for screening. So we often edit the larger guidelines to make sure they're more inclusive. And, we're very able to do this for other people outside of the UK as well. We also have seen some system-based solutions to the invitation issue that a lot of people face depending on their gender marker for screening. And as you saw earlier, we also create as a charity some specific screening campaigns that speak to our community and most importantly, represent our trans communities as well. But what do we need to do next? So we know, especially now more than ever, there is growing hostility to LGBTQ plus people, especially the trans and intersex communities. So we need to really address this so we can make sure that that mistrust that we already hold for healthcare doesn't start to override our ability to get early diagnosis and care. We need systems and policy to really understand and represent our needs so we can access life-saving screening or timely cancer care. We need to see better monitoring of sexual orientation, gender identity and expression and sex characteristics in both the patient records, but also the disease registries. And we also need some targeted support for people who are intersex as well. And as I've spoken about before, our charity is very proud to work quite strongly in the space of trans health as well. And it's something that we're very committed to. Next slide. So in the diagnostic stage, there has been some improvements, which is great to see. So we know that there is, for example, in the UK, a radiation law we have that has been rewritten to be inclusive of people of all genders when they're being exposed to radiation and have the potential for pregnancy. We also know of some ongoing work that we are involved in that's looking at HPV screening and also PSA screening in trans people to make sure that those systems work for us. But there's still more to go. So professionals really do often still lack the confidence, especially when it comes to one-to-one patient-professional interactions. So we'll be touching on that a little bit more lately. Then we also know that trans-specific guidelines still need to be developed for when there are potential changes to diagnostic procedures or the way we interpret tests to make sure that people, again, are getting the proper care. Next slide. When we get to the decision stage of the pathway, we have written and published some information that supports trans patients in particular. So we have published some non-clinical guidance that's around how to safely continue with gender-affirming hormonal care at the same time as receiving systemic anti-cancer therapies. It's a multi-professional piece of work that we're doing and we're ongoing in our updating of it. But we also in the UK are quite unique in having a service that's the UK Cancer and Transition Service. So this is a bespoke service for people who are trans and have these potential crossovers in care where they can get specific information and support. And my colleague Alison works internationally to try and make sure that this model is replicated elsewhere and that we support people with the information that we've gathered through supporting this service. But what else to do? So I think there is a growing call for bodily autonomy. I think that's something we have to support, especially when it comes to people's treatment decisions. Again, some disease-specific guidance for people who either are transgender or people who have variations in their sex characteristics. And psychosexual impacts need to be discussed. They can't be shied away from, and it's really important that we have those conversations as early as possible for patients. Into treatment, we can see, next slide, that we've seen some guidelines published. So YCE has some fantastic resources on this that we'll touch on later, but there's also some other ones that I've put on these slides you can go and look at. So there's guidelines for interpersonal skills, again, that radiation law I talked about, and then also guidelines that are inclusive when we think of intimate exams. But again, there's still more work to do. So at least in UK data, there's a rapidly falling patient experience for trans people. So that needs to be understood and combated. Again, psychosexual impacts are really profound and often under-discussed. And really, data is the thing that's going to help us here. So we not only do we need to collect the data, we need to interpret it and collect enough of it that we can make really good interventions that we can get other people to buy into. And I know Emily's going to speak about this a little bit later on. Into end of life, there has been a really good bit of work going on with our friends at Hospice and also an organization called GIAS, where they're doing LGBT specific end of life care, especially trans specific stuff. Really great documents of guidance if anyone's interested to look at that. Because 74% of our community still feel nervous about end of life care and worry about their identity being respected at that stage. So it's really vital that we do see this as part of the cancer pathway and something that we don't neglect, as well for the partners and support networks as well, because it's important that their grief is understood and supported in the same way as cis people's is as well. So in the living with and beyond, the final stage of this very quick whip through, we have seen progress really happening here. So there is growing support, growing conversation. This evening or this afternoon, wherever you are, is obviously an example of this. We also know that there is better inclusion more broadly for cancer charities. It's something that we're moving towards as an open discussion. And inequalities are even becoming core in grants and funding calls for research. So this really does show that there is a commitment there. But where to go next? Multi-year funding is important for inequalities work. Often they expect us to change the world in 12 months. It's not possible. So we have to think about the long-term goals there. We also need to reduce the postcode lottery that happens where LGBT work just happens in the bigger cities or the areas with more resources. This kind of work needs to happen across the countries and across Europe. And then also social prescribing, the idea of bringing in charities and social networks, that really needs to get much more support to be inclusive as well, so that each place knows of these services like LGBT support and others that are available, even if you are not in a big city. So that's the very, very quick whip through. I appreciate it's a lot, but it's really just intended to whet your appetite. And obviously, this is the webinar. Feel free to take photos of the slides and go and dig into this in a little bit more detail. So another thing that we've done on this, you can tell this keeps us very busy and why I've lost quite a lot of hair over the last few years, but all the stress is worth it because we're making progress. And one of the really good bits of progress we did was this report that we did with YCE. So we worked together to create the recommendations for equitable, diverse and inclusive cancer care in Europe document. And it was a really, really fantastic piece of work to come together on. So we had quite extensive methods. So we were looking at research, we did consultations, peer visits to actual clinical spaces, stakeholder engagements, lots of things going on here, including workshops as well. And what came out of the data, especially the survey data that we collected, was some real focus areas. So we had race, ethnicity, culture, and refugee and migrant status. We had gender identity and sexual orientation. We had age, physical and mental development and well-being. And then we had education, career and socioeconomic status. And it's really important to recognize that these focus areas came out of the data of both the patient group and the professional group so that we could get a holistic view of this issue. From this document, which I encourage people to go and look at, we made some core recommendations that come under some set themes. So I won't go into all the recommendations, but I will recap the themes for you. So the key themes that we had was strengthening EDI in research. So here we're thinking about improving patient data collection and also enhancing the research team diversity as well, making sure we're getting lived experience into those teams. We also were thinking about improving EDI in cancer services, obviously pertinent to the conversation we're having now. And in this, we mean providing culturally sensitive care and also promoting diverse representation in care teams as well. So the idea of positive pressure and making sure that we're constantly pushing towards EDI. And then we also thought about fostering diversity and inclusion with patient organizations. I think it's super important that patient organizations work with healthcare systems. It's the great way to make sure we hold each other accountable, but that we're also really able to share best practice. And then recommendations for the European Commission. So a lot of this work tends to happen in small pockets or isolation, and it's important that we start to activate the sort of international policy discussion and really set an expectation of what this care should look like. And Aleka will give some really good insight on how to do that. So please do take a look at this document. You have the QR code there. It's not too long, so don't be put off. It's not too scary. It's very accessible. And you can also take a look at all the different ways that we've talked about this and where we've presented it to. You'll get the full package. So that's my very quick spiel at the top end. Now I'm actually going to hand over and we're going to hear from Emily, and Emily's going to explain their work, how it relates to the YCE project and the impact that they've been able to achieve. Over to you, Emily.
Thank you very much, Stuart. So hi, everyone. My name is Dr. Emily Pattinson. My pronouns are they, them, and she, her. And I am an inclusion expert, basically, if anyone can call themselves that. I have a PhD in psychology. I've worked predominantly within health research, exploring increasing the accessibility of services for people in marginalised groups. And one of the projects that I was most proud of is a project called Queer Futures 2, which explored improving mental health provision for LGBTQ+ young people. I now work for an organisation called Inclusive Employers, and we are a training and consultancy organisation that support many organisations across the world. And I particularly work in supporting with data, training and cultural change. And so why I'm here, the relevance for that is that I was lucky enough to work with YCE on this project to co-develop and deliver an amazing training toolkit. So during this project, we worked together with key stakeholders from research communities, patient advocate communities, and healthcare provider communities to co-develop a training toolkit that really explored the main needs of these groups in supporting and advocating for increasing the quality of care for people living with cancer. So the main topics, you're going to be able to download this toolkit, have a look. It's available in lots and lots of languages. There was a lot of work that went into making sure it's very relevant in lots of languages. So do download it, get involved, have a look. The main areas that we explored based on feedback from key stakeholders was cultural competence. So that idea of wanting to be able to provide a high quality of care that requires confidence that you know about the needs of the communities that you're going to serve. So we really explored that deep cultural context and often what's largely unsaid, especially in relation to the LGBTQ+ community, to be able to identify and have conversations, which led itself to inclusive language. That was something that lots of people tell me what I'm allowed to say and what I'm not allowed to say. So we really explored that kind of how to connect better with the individual, how to ensure they feel heard, and how to support them to advocate for themselves. And so we really explored that kind of from an LGBTQIA perspective. That toolkit goes into exploring gender neutrality, especially in gendered languages like French or Spanish. How do we really ensure that we're using the right language? Yes, it is possible. It's very hard, but it is possible. So there's lots and lots of information in that toolkit around how to explore that kind of language in different languages. And then finally, we looked at the individual's role. because what we wanted to do is really equip clinicians, researchers, and patient advocates with that ability to apply those skills around advocacy and agency for young people directly into their role, and how to be an ally and how to push for systemic change within their organizations. So the way this worked is we took a train the trainer approach. We invited key representatives from lots and lots of different organizations across Europe, some of who are on this call today, to come and have that training delivered to them. That allowed them to be able to kind of hear from experts, understand how that training works within a workplace setting, from myself and my colleague Nozomi, to understand how to take that away and share that learning with their colleagues. And the reason we decided to take that train the trainer approach is because it's scalable. You know, this was an EU funded project. We wanted to make sure that we could apply this to the whole of Europe, but we couldn't exactly go around every single organization in the whole of Europe. So we wanted to be able to get as big a reach as possible. And it's also train the trainer approaches are very good at enforcing accountability. Having an expert come in and share their perspectives is absolutely wonderful, because it means you're getting access to that really nuanced knowledge. But having a core-developed and core-delivered approach where the people you are accountable to are the people that you work with day in, day out, means that cultural change is a lot more predominant and faster when compared to self-directed learning or externally delivered training in isolation. You know, the basics are people tend to do more when the person that they're accountable for is someone they see every day. So I have the next slide. And just to, as you know, we only wrapped up this first pilot and started releasing this training out into the world in sort of 2024, but the impact already is enormous. You know, even just in the summer after the training, we saw a 41% increase in our attendees' understanding of the importance of EDI in relation to cancer care. We saw a 34% increase in confidence to challenge discrimination directly in their roles, and a 45% increase in the confidence to push for strategic change. And we've seen that already in terms of organizations pushing for their institutions to have EDI strategies, or to deliver this training, or to get external speakers like ourselves in to come and deliver that. And a lot of the time, I know I don't have to tell you the value of doing this. You're here, you're at this session, you want to add this into you. But often the barrier becomes things like budgets or senior leaders, convincing them. So just to give you something to take away when you want to think, how can we implement this in our organization? I want you to take away just a little, I did a rough calculation of, so we took that 41% in increasing understanding of the importance of ED&I, and I did a really quick return on investment calculation to show how much this would save an average size healthcare hospital or trust to implement this. How much would it save them? And it sounds unbelievable, but I mean, I've done this in pounds, but you can apply it to euros. £30 million it would save by creating a better quality of care, better understanding of ED&I, because it reduces, even just from a staff perspective, lowering absenteeism, lowering turnover, and higher productivity. So that's not even touching on the benefits for patients. Just the benefits internally for employees could potentially save up to £13 million, which is just silly numbers. So you're going to get the chance to download it. Please do. Even if you're not super confident on how you're going to apply it yet, download it, read it, use it for your own personal learning. And if you do want a bit more support to roll that out like to the whole organization, reach out to me. I'm more than happy to have a chat with people and talk more about how you can apply this to your organization. But I've probably gone over my 5 minutes a little bit, so I'm going to hand back to Stuart for the next speaker.
Thanks, Emily. Don't worry, you didn't go over by much at all. So next we're going to hear from Aleka, who's going to talk to us about the work that she's doing with European Cancer Organization. Over to you, Aleka.
Thank you, Stuart. Hello, everyone. I think we can go next to the next slide. So all of the work that I'm going to present is done under the LGBTIQ workstream, which is part of the ECO Inequalities Network, which is chaired by Stuart. We have them here today and Nicola Battisti. Next slide, please. So I wanted to also give a bit of an overview of what we've been discussing, but also why we are doing the LGBTIQ survey. So last year during Pride Month, we released a report that identified some key issues like data gaps created by lack of diversity and intersectionality in research and clinical trials. We identify poor cancer outcomes for LGBTIQ individuals due to institutional stigma in healthcare. We've seen some surveys with healthcare providers, and almost 90% of them believe that trans people are at risk of discrimination in healthcare, which is an insane percent to think that basically everyone knows that some issues exist, yet they are not being solved. And we've also seen that LGBTIQ individuals have lower participation in screening campaigns and other patient-targeted programs. So why does this happen, and how can we bridge it? Next slide, please. So we think that we should start with policies change, obviously, and this needs to be done in collaboration with LGBTIQ representatives to create inclusive policies. You can't do it sitting in your own bubble and not asking somebody else's perspective. So obviously, we have to include LGBTIQ representatives at every step of the way when we build new policies, either that they are referring to education and training or screening and treatment or other social and healthcare interventions. I think we always need to take into consideration LGBTIQ advocacy groups and the community members, and also not in a tokenistic way, but really involve them. Next slide, please. We realized that we know that a lot of these issues are happening because we have testimonies from a lot of people, yet there's not that much data on it. And more than that, there's not much European data on it. There's loads of data from the US or from Australia, but there's not that much in Europe. And for example, we know from EUFRA report LGBTIQ at the Crossroads that 45% of LGBTIQ people in the EU report difficulties accessing healthcare, and especially trans women, men, and intersex persons. So because of this, next slide, please, we decided to do this survey. And to do this survey, as I said, we didn't want to just put some questions together and ask people something. We really try to involve an expert group formed of researchers, patients, medical oncologists, and civil society to ensure that it is reliable and it is valid, and the data that we have can be extrapolated to a larger audience, and we can speak about issues that really affect the community, and we can target issues that are solvable at this moment with some resources that we do have. Next slide, please. So it was launched in November, but so far we only have the English version of it. You'll see what's coming next at the end of the presentation. But right now we're in the data collection phase. We expect to have some more results by Pride Month. But the full set of results and the report that comes with it, we will have it by the end of the year, more specifically in November. It will be launched at the next European Cancer Summit. Next slide, please. And again, next slide. So to understand a bit the survey structure, obviously the first part is asking for consent. We ask for consent for both quantitative and qualitative data because we would like to use the qualitative data in the report and also maybe in communication. Then we have the demographics part, and we really try to align what we're asking with the Eurostat guidelines. So we have some framework of reference when we will try to compare some of our results to results from other studies or results from Eurostat themselves or from ECIR and others and other tools that relate to European data. The third part is about the experience with screening, and we try to understand the participants' experiences with cancer screening, like satisfaction, behavior of the healthcare professionals that perform the screening, and so on. Then there's a lived cancer experience part, but so far, unfortunately, we only had one participant with lived cancer experience in our survey, so I won't present data from this because, well, it's not yet statistically significant. And then the last part is about attitudes towards healthcare in general, because we wanted to see how LGBTIQ individuals feel and what they think about healthcare in general, and see if it relates to their experience with the other things that we're asking. Next slide, please. So I'll go really quickly through the sample overview. So far, we've only had 37 participants. The age range is quite interesting, from 18 to 67. We've had loads of participants from Croatia, almost half of our sample so far, and then Italy, Austria, Denmark, Greece, Netherlands, UK, Belgium, and German. We do have translation in 17 other European languages. So I do think that participation will increase. And it will also increase in diverse countries, which will be great for us because we will be able to have an overview of what's happening also in different countries across Europe. Next slide, please. In terms of sexual orientation, we can see that it's also quite diverse, and we don't have too many people from only one category. Next slide, please. And then in terms of gender, in here, it's also quite balanced. And also what was surprising was that half of our sample is trans, which we thought that it would be quite hard to get this much variability in terms of our sample. But it's nice to see that we will get different perspectives, and we can have some intersectional results and assumptions at the end of the study. And next slide, please. And in terms of sex characteristics, 20% of our sample describes themselves as intersex. Next slide, please. Other sample characteristics are that almost 20% experience difficulties in making ends meet. 15% consider themselves to be part of an ethnic minority in the country they receive their healthcare in. And also 40% are part of another historically marginalized groups, like people living with a mental health condition, religious minorities, or people experiencing homelessness, etc. Next slide, please. So for the screening part, we can see that 35% of our sample has already had breast cancer screening, 27% has already had cervical cancer screening, and almost 12% has had colorectal cancer screening. These numbers are not adjusted to the recommended age to get cancer screening. So this is an overall sample percentage. So obviously the number one for never having had cancer screening is that no cancer screening is recommended for their age group. In this part, we found out that 30% of our sample are afraid of disclosing their gender identity to the medical professional. But 75% were satisfied with their overall experience with cancer screening. And unfortunately, around 20% felt that the medical professional doing the screening was asking an intrusive question about either their gender identity or sex characteristics. Next slide, please. So, as I said, we don't have yet any responses for the cancer part. Lived cancer experience part, but for medical mistrust, we found out that more than half somewhat disagree that doctors have the best interests of LGBTIQ people in mind. Also, more than half somewhat disagree and strongly disagree that LGBTIQ people receive the same medical care from doctors and healthcare workers as people from other groups. And 30% agree that they have been personally treated poorly or unfairly by doctors or healthcare workers because of their either sexual orientation, gender identity, or sex characteristics. Next slide, please. And I did a selection of some of the testimonies that we've had. We are asking after each section if people want to tell us anything else about their experience. And there's also a general question at the end that asks just, do you want to tell us anything else? We have here some of their confessions. A bisexual non-binary person from Croatia told us that they wanted to do a procedure to preserve their sex cells and was denied care by every healthcare institution in their city. Although, from what we know and from what they told us in Croatia, it is guaranteed by law that you can preserve your sex cells. A queer trans man, also from Croatia, said that they are convinced that if healthcare providers knew that they were queer, they would receive worse healthcare service even in private institutions. A bisexual demi-female, so a person with intersex variation from Austria, told us that they felt unseen, unheard, and neglected. A bisexual woman from Greece told us that the doctors usually hide the fact that they completely lack expertise on intersex or trans bodies. So we circle back to the cultural competence that we were talking about. And then in the end, a pansexual woman from Germany told us that it took them so much time to find a doctor with knowledge on intersex variations. So this have been quite shaking when we read them, but I thought it would be quite a good selection of testimonies to show with examples that the problems that we're talking about are indeed real and they affect people on a daily basis, but there are struggles that we just don't see. So next slide, please. Next slide. So next steps, as I said, translations in 17 languages are coming. We're currently in the review phase. Hopefully they will end soon. And then we will be able to send you the survey in all of these languages. And also it will be accompanied by a dissemination toolkit comprised of visual, social media, ready to post text, and everything. It looks really nice and I'm really excited for you to see it. Yeah, that's the end. I think the next slide is my email. It's quite simple. It's my name at europeancancer.org. But of course, you can find it on the website or you can ask anyone here, and I'm sure they will be able to redirect you to me. Okay. Thank you so much.
Thank you, Alika. That was super insightful and really exciting early stages of some important work, I think. So when that toolkit goes live, absolutely keep an eye on ECO's channels, my charity's channels, all places where you can sort of see this stuff because it's really going to help us get some data that really moves policy forwards, we hope. And also, I think I'm really grateful that you shared that early data we have. It really shows the importance of mixed methods and having both the data and the stories. Wonderful. Okay, so we are on to the panel part. So I've got a couple of questions here that we've given the panelists so they have a chance to prepare their responses. So we're going to run through those. But if you are in the audience and you have a burning question, please do pop it in the chat. I'll keep an eye on it and I will try and weave those in, or we'll try and save some time for them at the end. So just to get us started, I'm going to come straight to you, Aleka. So very sorry to hit you after you've just done that long presentation. But you talked a lot about systemic level inequalities, and I think that's the important part of your work, right? You know, it's how do we build the policy and the systems to be better. And I think this is important because a lot of times this stuff gets locked into the idea of individual experiences, but it misses the idea of data, patient records, inclusive trials, all these sort of things that are very important. So I guess from your work that you've done and from the early data you've seen, what do you think are the most urgent changes that we need at the policy level?
Well, first, I think we do need to all agree that we actually need to collect data in everything that we're doing. So either if we're talking about member states and the just general data collecting, but also in clinical trials, in research, I think a lot of the times, whatever surveys we are completing, any one of us, we could see that there's only, when you have to say which is your gender, you only have male, female, and other. But in that other, there's so much richness of choice that I understand that for some people it might be even hard to think how can we include this, but the thing that we're not trying does not help. So I really do think that everyone should slowly but surely, or maybe a bit more faster, get to that and start collecting the right data. Because once we have that, we will actually be able to see how diverse the world around us is. Because we think that, oh, I have a gay friend, or oh, I have a trans friend, and that's the only thing that you know about an entire category of people. And also, people are talking about LGBTIQ as if it's an umbrella that everyone is the same in that group, and it's not. So we need to collect data and we need to disaggregate data. And once we have this, we will be able to be more targeted with the campaigns that we do, the screening campaigns that we do. We'll probably realize that the screening campaigns that we do are gender-based right now, and that doesn't really help us because it makes some people just not go because they don't feel included in that conversation. Of course, they know they have those body parts that you're talking about, but it's just not for them because you're not talking to them. So I think that's one part. And then the other part, as we talked about, is the cultural competence and actually having a top-down approach from policy level to member states, talking about the European Union, but also further than that, we need to have frameworks that actually train healthcare professionals to be aware of these issues, but not only to collect best practices, to stir a bit the conversation and ask, hey, have you ever encountered a person belonging to this community? How did you deal with this? Because I think a lot of the stigma comes from the fact that people really don't understand. They don't really know how to deal with this and they just decide to completely ignore it because if I ignore it, maybe I won't do the wrong thing. I think also Emily said like what are the correct words to use? So people are really confused and some, although they might have good intentions, in the end they don't do the good thing. Because it's really complicated for them to know which one it would be. But that wouldn't happen if you've had actual training and if you really know at least where to look for the right information. So I think these are the most burning issues, I would say. I hope I didn't talk too much
No,
on this.
no, never,
But,
never too much. No, it's super useful, I think, to hear your policy insight on this because we often hear about local projects, initiatives, small impact, and it's really great to hear about that top-down pressure and setting the expectation of improving care. Thank you for that insight. Okay, I'm going to move over to Levi now. So we're moving the conversation on to thinking about integrating that lived experience that Aleka was just talking about, right? So the idea of how do we actually then center the voices that matter most when it comes to designing the care and the pathways for them. Because we know that even when people do have some knowledge and some training that we sort of alluded to, sometimes it can be theoretical, or it may be that people haven't directly supported a trans person yet or an intersex person. So they feel, even though they know the knowledge, they're unprepared. So, with that understanding, Levi, I'm wondering from your perspective, how do you think these sort of training programs and these policy discussions, all these things we're having, how can these be improved by people with lived experience taking part?
So thank you. And I think that it's hard to create one size fits all scenario for this. But from what I can like generalize is to actually talk to queer people. And I know that at least here in Czechia, and I believe in majority of the countries, there are organizations, nonprofits, that don't necessarily focus on healthcare, but general. If I can say the name of one organization that I know is here in Czechia, and it's very awesome. It's Transparent CZ. And I do believe that if someone like a healthcare professional reached out to them, they would be able to connect people. So overall, I think the experience can be connected via these organizations that every country, I do believe a majority of the countries have. So it's really as simple, quote unquote, as talk to queer people, ask us what we need, what we want. And how you said that if a doctor has not yet treated a trans person, honestly, chances are that they probably have, they just didn't know.
Mm-hmm. So you said a really interesting thing there about, let us speak for ourselves and what we
Mm-hmm.
want. And I definitely believe that and embody that too. So I guess for the people who are watching,
Mm-hmm.
are there any sort of key themes or themes from your experience that you think are important for people to remember?
I think that the most important thing, and I believe we will get to this point a little bit later, but safety and privacy. Uh, Queer people need to be assured that they have privacy, that just because a patient is trans, that the patient is non-binary, intersex, that they are not subjected to questions that a cis person would be subjected to. So, for example, from my personal experience, I have been asked multiple times about the development of my chest, and I am not very comfortable regarding that topic. And I know from friends that I made during treatment that they have not been asked that, whether they were male or female. So definitely safety and privacy is the most important theme that I would say needs to be addressed.
And that's such a powerful point. And it's something that I think in the years that I've been doing this work, I've really thought about as well. So it's really interesting hearing you say the same thing, that I think there's often a lot of expectation for visibility from us, but it doesn't recognize the vulnerability that we are in when we are visible. And I'm thinking about this a lot with Trans Day of Visibility coming up and everything obviously that's going on in the world.
Exactly. And one more thing I would mention to this is that not every queer person is willing to educate.
Yes.
Because that is something that is oftentimes an expectation that, oh, you are trans, explain that to me, which is not often the case. I want to say there are people who are willing to educate, as majority of this panel, but not every single person. So again, safety, consent, ask, hey, could you please explain this to me? And if they say no, take it at that and be like, okay, cool, I won't inquire further. That is, I think, the most important bit.
Fantastic point. And I definitely think it reminds healthcare professionals to always remember that it's their duty to be informed as well, and to do this work, which takes us very nicely onto Emily. So, Emily, I wanted to talk to you around your training and the impact it has. So you sort of alluded to earlier, impact and money saving. And I think from someone who also provides education, I know that it often does come down to the bottom line. It's really an important thing when people are deciding to take that journey. So I guess when we think then around when people do include these policies we recommend, how do we make sure then that people are continuing to provide that good care? How do we make sure that it goes from beyond the toolkit and into practice? So in your experience in creating that lasting change, how have you gone about measuring that and then reporting it and trying to build that momentum?
Absolutely. And I just want to draw how important that point from Levi was around, and the reason why organizations choose to work with like organizations like myself or yours, Stuart, that just because someone has a particular experience doesn't mean it's their job to educate. I feel sometimes when I get asked personal questions about my own gender or my sexuality, I feel like sort of turning around and saying, Google does exist, like Google it. But I choose to be an educator. That's my choice and that's my job, but it's not necessarily everybody else's. So I suppose that's why we developed this training, because we recognize that we spoke to those with lived experience and developed this training to allow them to not have to be the educator, but the content be there with their voice, but not have to be their energy. So I think it's, first of all, it's shifting mindsets. That is really hard. And I know there'll be a lot of people on this call where they're thinking, I love this, I get this, but there are doctors or leaders or people in my organization who would not want to have this conversation. And I think having that toolkit, having that information, having that support around how to challenge biases or build that cultural competence in a way that is supportive is really, really helpful. And that can be measured. I mean, we measured it in sort of retrospective surveys. So after people had done the training, we asked them, how would you rate yourself before the training? How would you rate yourself now? To explore that shift in attitudes. You also, when you're looking at it from an improving patient outcomes perspective, because increased confidence in clinicians and patient-facing staff will have a knock-on effect on that building patient trust, enhancing clinical outcomes. And you can see that in patient feedback, but also in things like a reduction in complaints, improved health metrics. So there's things there. And then also, whilst we it is important to focus on that patient care, the sort of staff experience has a knock-on effect on patient care as well. So reducing staff turnover or absenteeism will help maintain a level of consistency in cancer care, reduce cancelled appointments. So being able to track that in terms of HR data like staff turnover, cancellations, really helps you understand, is that experience differing? Because if you're noticing that lots and lots of LGBTQIA people are experiencing maybe an increase in cancellations or inconsistency in their care, that's then going to have a knock-on effect. So, I mean, I know I'm just touting this training over and over again, but to read it, get involved. It's available in loads of languages, because the effect is so much more like than that person to person. But it starts with that person to person. If you as an individual can improve how you communicate with your LGBTQIA patients, people will then learn from you. And it has that massive knock-on effect.
Absolutely. And I definitely resonate with what you're saying as a patient. You know, that relationship to your healthcare providers, if they see you and understand you, it's so much better and you're more likely to turn up for treatment, advocate for yourself. All of these things are so important to care. So thank you for that. And I really value your point about accountability between staff as well and making sure that there's no discrimination between people, especially if someone is putting themselves out there to advance things, making sure they're supported rather than blocked as well, which I think is another really key thing. Okay, so we're going to go back to Levi and Aleka for a conversation around this idea of data and policy. And it sort of speaks to something you just mentioned, Levi, before about this idea of privacy concerns. And I guess I'm interested to hear from both of you this idea of we're sort of caught between two competing ideas, really. We need more data, we absolutely do. But at the same time, we're entering a time and have been in there for a while where our community is very shy about giving this data because of very real safety concerns. So how do we really try and balance that or win people over to understand the importance of their data? So I'm going to come to you first, Aleka, and then I'm come to you, Levi.
So I start.
Yeah.
Okay. Sorry. Yeah. Well, I think this is complicated, but of course, every time we as all of us, we as society ask somebody to give us certain data about themselves, they should always have the choice to just not do it. And that's a perfectly valid reason. I don't want to do it, and you just don't. But then I think from a policy point of view, how can you sell what you are doing to make people to actually understand the value of them giving the data? Is that you have to actually explain how it is going to be used, what's its purpose, if you're using this data, what's the benefits that that person will have from this policy or the survey or whatever you're doing, how it can make the world and their lives better. And that would be a fair exchange. But of course, the question of privacy is really big, and it also depends on the policies that exist in every country, because we do know that, for example, when we talk about health records, they keep really old data and people don't really identify with that data anymore. What do we do? When do we delete data? How do we keep it up? We're also seeing what's happening in the US right now. It's a mess. So I think that the answer to this question is obviously I'm not necessarily the best person to answer it, because first of all, I represent no type of diversity, and second of all, it's really a question for the LGBTIQ community to decide how they want themselves to be perceived in front of institutions, in front of states, in front of organizations. So, yeah, I think this is the end of my answer, because I can only say that we need to include the voices of the people that we're asking the data from in this conversation.
But I think you make a great point, because I think what people often miss is that every episode of disclosure that we make as queer people is a cost benefit analysis, right? Of, does the potential harm here outweigh the potential benefits? And I think that you're right, is how we help people understand. And I think this comes a lot to when people talk around inappropriate questions. Sometimes we have to ask specific questions for medical care, but we have to be able to justify that question. If we're just asking questions without justification, then it starts to feel intrusive. And I think that balance can be really tricky, especially for those of us who have an intersecting identity. So people of color who are also queer, and that fear of disclosure that happens and gets back to communities. And I'm wondering, I've definitely felt that kind of fear of disclosure, even though I'm sort of a very public advocate for this space. And I'm wondering, Levi, how it's been for you as well. Are there, you don't have to give me any personal anecdotes necessarily, but that sort of feeling of that balance and motivations for disclosure, are there any things that motivate you to share that information?
Well, what would motivate me would be knowing who exactly gets the access to the data. Because, for example, I can imagine that it could be hard for a young queer person who's getting treatment. Maybe they trust the doctors, but they know that, for example, their parents, their immediate family or caregivers would not be tolerant. So I believe that the information of who gets my data would be very motivational for young people, because when done right, the medical professionals and staff should be at least somewhat educated. But when you have, for example, a father who has never once stepped foot in any sort of education about queer people, you cannot expect that person to really know what, for example, oh, the child says I am non-binary. You cannot expect the person to exactly know. And as per my previous point, you cannot expect the person to educate. So it would really be beneficial to know exactly where the data is going, not only why it's going there, but who is it going to.
Super
Mhm.
interesting. I just want to quickly add that someone in the chat actually mentioned the importance of family being educated as well, and
Mhm.
I think you raised that really good point that you know quite quite a few of us often have experiences where our family are not super
Mhm.
aware of how our identities are expanding or exploring, or how we even navigate our identities in our communities. And I definitely, as a patient, have found that the strength I find in my community is something that isn't always understood by healthcare professionals or my family.
Absolutely. And this is sort of like the privacy and everything is an issue that needs to be addressed more systemically, where um, the information given by the patient, unfortunately, this happens, as was mentioned, the situation in the US, the information can leak out, which is very unfortunate, but it does happen. And so I think ensuring the safety of the data is also incredibly important.
Oh, I think you're absolutely right. And it's something that's come up also in my research career. So beyond just the sort of clinical advice stuff, it's also, we've had, well, when we do research, especially with trans communities, we always co-design and develop things right from the beginning. And a question that's been coming up more and more, because as you point out, data does get leaked or companies go bust and data gets sold and, you know, all of these things that happen. There's been a real question around from the research process, what data gets collected, at what level, and what data remains available for review articles and meta-analyses, and how will that be shared? And I think what is coming from me, from all the panelists really, but it's this idea of us being able to make informed decisions so we retain some autonomy around the way that we not only access health, but the way that we're recorded within health as well. So really important stuff. I just want to close out on a last question for you, Levi, which is that idea of community and its importance, really. And you already mentioned one fantastic organization. So I know that through the charity work I've done and my queer community, it's been a really strong sort of support for me, a real strength. And I'm wondering for you, how do you think better peer support programs could be built into the cancer system so that people are less likely to feel alone?
Well, luckily, from my experience, these programs already exist. Not necessarily focused on queer patients, but in the hospital that I was treated as, there was a craft group where the children could go and make things, or there was a therapy with dogs. I forget the name. So in my experience, there are peer support options, but they're unfortunately often underfunded, which could really nicely tie into what Emily was presenting with the saved money from better understanding could go towards these peer support groups. So I think this all ties very, very nicely into generally mental health of the patients. Because again, from my experience, the craft sessions that were happening, the kids there weren't so exhausted and tired and sad as they were tied to their hospital beds. Yes, they were still hooked up on IVs. However, they weren't focused on the illness itself. So yeah, short answer, better funding.
Yeah, I think from us running a service, I definitely agree with that. You know, I think so many of these services pop up in community groups as well because of the lack of funding, but then that makes them vulnerable to external pressures, cuts in funding, you know, key health issues. So it's really, really lovely to hear that you found a craft group as well. I think that's such a lovely holistic thing to do with each other. And it reminds us that peer support doesn't always have to be about the disease. It can just be about connecting, about the experience of it all, rather than sometimes the details. So thank you. Thank you to all the panelists. It's been really useful. Sorry, Levi, do you want to say one more thing?
Yeah, one more thing
Absolutely.
that I want to shout out. Like, definitely look for groups in your area. Support your local communities. That is, I think, the most important thing to take away. Because, for example, here where I live, there is a community that has an event as we speak that I shared this meeting with. So I hope some of them are here. So yeah, that look for local communities. That's all I wanted to say.
Wonderful point. Thank you. And if anybody's thinking about setting up an LGBT specific cancer group, absolutely get in touch with YCE and Outpatients. We're always very happy to share what we've learned, what's worked, what hasn't, so that you can hit the ground running. I think the more local options that are available, as Levi points out, the better. It's really vital that everyone gets support in their local areas in the way that they see fit. So that was a really fantastic panel discussion. Thank you, everybody, for being so candid and being so considered in your answers. I hope people have taken a lot away from it. I'm now going to hand over to Carmen, and Carmen's going to take you through the next few slides.
Okay. Hey, everyone. I'm Carmen Monge. I am a researcher and patient advocate for Youth Cancer Europe, and I'm going to introduce the work that we are going to do in Youth Cancer Europe in the next years. So Sorry, now you can see me. Okay, so one of the things that we are planning to do and that we are going to do is an inclusivity checklist and certification system for healthcare institutions. Why? Because on the survey, we saw that doctors and healthcare providers were saying like, yes, we are super inclusive, diverse in our healthcare system, but the patients are saying another stuff. So we want to put everyone on the same page. Also, we want to do a self-assessment checklist for patients' communities so they know how to deal with every one of the communities, underrepresented and the minorities. Lastly, we want to make events inclusive for everyone. So it doesn't matter which community are you from. We are going to have guidelines so other people, not only us, but other people can follow these guidelines and feel everyone welcome. So keep tuned for all our plans for the next years. Also, if you cannot wait until see all these goals that we have, we invite you to see some of our resources that we are putting here on the webpage. Here are the QR codes, but my colleagues are going to put all the resources that Youth Cancer Europe has on the comments below, but also all the resources and all the links for outpatients or for inclusive employers or for the European Cancer Organization, that they have amazing resources that you can learn a little bit more about what they have done, what they're going to do, and how we can collaborate together. So if you want to know more about EDI, apart from this topic, keep tuned because in 1 month we have another webinar, and this one is going to tackle about socioeconomic status and cancer inequalities in Europe. And it's going to be kind of with the same format, and we are going to have very exciting guests and speakers that are going to introduce us the topic. As well, we are going to have people with a lived experience that can explain a little bit about their experience on this topic. So thank you for looking all the webinar, and we are going back to you, Stuart. Thank you.
Thanks, Carmen. And thank you to everyone that's joined us this afternoon/evening. It's been really, really interesting to hear from all the panelists and all the various speakers, and also to read your comments in the chat. It's been a really wonderful event. Thank you so much. If you do have any additional comments in the chat you'd like to make now or links you want to share, make sure you get them in so other people can share them, especially if it's an email to connect and keep doing this kind of work. So the link for the next webinar is also in the chat box as well, but you can also scan that QR code. These are really, really important discussions that YCE are hosting, so we hope you can make it to the next one. I want to thank all the speakers individually as well, Levi, for sharing your lived experience. It's been super helpful to understand where you have navigated the system and where you think those wins can happen. Emily, for your experience with educating and creating the toolkit and advertising it in such a strong and compelling way. So I hope everybody takes a look. And obviously, Aleka, my dear colleague, and the work we're doing on the survey. Really wonderful to hear also about that top-down pressure we can create and the importance of data in doing so. So thank you, everybody. Thank you for your time. Do connect with all of us individually or YCE directly if you want to keep doing work in this area. We're very excited about the progress we've made and can't wait to do more. Thanks, everyone.
Thank you as well, Stuart.
Thank you to you, Stuart.
Thank you.
Thank you.